This is Dr. Paul Kanev, Senior Pediatric Neurosurgeon at Children's Hospital of Philadelphia. I'd like to talk with you today about Baclofen pump therapy. Baclofen is a gamma-butyric acid type B agonist, augmenting the natural neuroinhibitory function of GABA. It's available both for oral and intrathecal delivery. It has proven highly successful for tone management in patients of all ages with cerebral palsy and spasticity caused by spinal cord injury and multiple sclerosis. The FDA approved implant and Baclofen pump management for children and teenagers in 1996. Oral Baclofen proves to be very effective for spasticity management in young children with cerebral palsy, especially children who do not have much large muscle mass. The optimum candidate is commonly ambulatory without dystonia. As they grow taller and increase their muscle bulk, however, the medication proves less effective. Dose escalation becomes limited by nausea and the sedation side effects of the increasing dose. In contrast to selective dorsal rhizotomy, Baclofen pump therapy offers advantages and disadvantages. The advantages include the non-destructive nature of the implant. Surgery is typically an hour to an hour and a half, and hospitalization is shorter than following rhizotomy. The operation allows the medication effect to be trialed and confirmed to the patient, his family, and caretakers. The disadvantages of pump management include frequent complications of pump or catheter malfunction, system infection, and scoliosis. Intrathecal Baclofen introduces dependency upon a medication, which has significant overdose and withdrawal complications. The routine follow-ups necessary for refill, dose adjustment, and troubleshooting may prove to be difficult access for families traveling from far referral communities. Many times, Baclofen pump therapy is trialed through a single-dose injection by lumbar puncture. The advantage of the trial is confirmation of allergy freedom of the medication in a child or teenager who may be naive to the medication from previous oral use. The trial effectiveness peaks at 3 to 4 hours after injection, allowing the benefits of tone relaxation to be observed to the care team, family, and the patient. Nearly all patients with cerebral palsy with both spastic diplegia and quadriplegia who undergo trials have successful trials, and more implants are being done now without that prerequisite. Baclofen pump is now possible to implant with insurance coverage without a pre-operative trial. The pump is inserted subcostal. We use the Synchromed 2 pump. A catheter is then tunneled around from a subcostal implant site into the spinal canal and guided cephalad under fluoroscopy. The Synchromed 2 pump was quite a refinement of the earlier model. Its drug refill chamber is doubled to now 40 mLs. The pump is smaller in size and weight with better contour, allowing its bulk to be hidden better in children who have thin abdominal walls. Its interrogation and programming is quite flexible, and it can be programmed to deliver a complex management of repetitive bolus therapy. The Ascenda catheter manufactured by Medtronic is available in 1 or 2 piece models. The pump segment attaches to the pump with a snap connector, minimizing the ties that are necessary and shortening implant procedure. In contrast, however, to VP shunt catheters, the Ascenda catheter is not antibiotic impregnated. The technique that we prefer operatively positions a child in a lateral decubitus upon a vacuum molded beanbag. The site of left or right subcostal insertion is selected based on the handedness and preference of the operating surgeon. We prefer a linear incision subcostal, about 4 centimeters wide for pump implant, rather than using a curvilinear one. A small lumbar incision is fashioned in the midline for catheter insertion. We guide the catheter fluoroscopically intraoperative. Once the guide wire is removed, the catheter is not visible any longer on fluoroscopy, and even with troubleshooting in emergency departments can be very difficult to see. We routinely use IV intravenous antibiotics during surgery of vancomycin. When there's a diaper use, gastrostomy, or tracheostomy tubes, we'll augment that with gentamicin, 2.5 milligrams per kilogram. We prefer subfascial pocket implant because the fascial closure minimizes seroma and restricts migration and mobility of the pump. It may, however, be a little more sensitive in older patients during refill because of the fascial innervation. Some patients have very complex abdomen challenge with both gastrostomy, urine diversion openings, or jejunostomy tubes. In children felt to be good candidates, we recommend a subpectoralis pump location. We generally recommend T8 to T6 location for diplegia patients and catheter tip localization between C6 and C8 for children with quadriplegia. When using the two-piece system, we anchor the catheter rigidly to the lumbosacral fascia with non-absorbable Prolene sutures. This anchors the catheter to avoid migration with the frequent twist, torque, and turn of many children. Adopting many of the techniques of VP shunt insertion, we use a shunt sheath technique rather than the tunneler provided by the company, and we try to adopt the shunt checklist and no-touch implant procedures that have proven successful with shunt surgery to minimize infection. Many children, because of their high muscle metabolism tone, have very compromised weight. We desire patient weight exceeding 15 kilograms, and we recommend surgery be restricted to children with BMIs greater than 15. Before insertion of the catheter, we recommend AP spine radiographs to serve as a baseline, confirming spine alignment or, if any, deformity to guide intraoperative insertion. We repeat these films to monitor for treatment-related scoliosis if a clinical curve progression becomes apparent. The initial dose of Baclofen after implant is either twice the trial dose, or if a trial is not done, we begin typically at 65 to 100 micrograms per day, depending on the size and the age of the patient. Serial dose adjustments are then made as necessary, inpatient or outpatient, every 1 to 2 days. The most recent Synchromed 2 programmer is a tablet design. It's backlit. It's very user-friendly compared to the earlier New Vision programmer. The programmer communicator is a wireless connection, providing very easy access. Baclofen withdrawal occurs when there's a reduction of the delivery of the medication. As the receptors are saturated, withdrawal and hyperactivates the nervous system, inducing global spasticity, fever, itching, dysautonomia, and in some severe cases, hallucinations or delirium. Acute Baclofen withdrawal in earlier series carries mortality approaching 33%, and presentation can mimic neuroleptic syndrome, sepsis, and hyperthermia. Emergency room protocols are very important to establish in partnership with physicians from those departments. Initial treatment is delivery of a bolus through programming, and if there's no response or there's ample Baclofen in place, surgery is very quickly done to restore intrathecal delivery. We use medications including high-dose oral Baclofen, diazepam, sometimes propofol, and the anti-serotonergic medication Periactin to minimize the wide swings of symptoms after Baclofen withdrawal. Intrathecal Baclofen is an ideal management for spasticity related to cerebral palsy. These children are ideally managed in a multidisciplinary team with specialists in physical therapy, neurology, rehabilitation medicine, and orthopedic and neurosurgery. Regular follow-up and protocols are necessary for refill scheduling, troubleshooting, and emergency withdrawal management. Thank you very much.